Next talk is Moving with the Ages, Recanalization in Acute Ischemic Stroke. I will request Dr. Trilochan sir and Dr. Vikram Bora sir to come upon the dais, and I will invite Dr. Shakir Hussain sir for the talk. I will invite Dr. Sushil Tapadia sir to present a book. Dr. Tarachand Joshi, please come on the stage to present a book to the chairperson and speak. It's my honor and privilege to introduce Hussain. He is my mentor, and he is not only my mentor, he is mentor of many students around the globe, in India, in Asia, and in Europe. Fajrji is working at Devi Memorial Hospital, Calcutta, New Hospital, Noida, and University Hospital, Zurich. He has 25-year experience of neurointervention, and he do all kind of interventions, all vascular kind of interventions, and he has a lot of award and honor to his credit. I think we know introduction, particularly in Rajasthan, because he belongs to Rajasthan. Over to Shakir sir.
Thank you, Dr. Trilochan. At the outset, I would like to thank Dr. Suresh Gupta, Dr. Madan Mohan Gupta for this opportunity. So I will quickly go to the topic. Good afternoon, ladies and gentlemen. So the topic which we are going to discuss is what is currently making a lot of vibes in the global arena, that recanalization with some kind of intervention that is performed. Stroke treatment management, in conventional sense, we can classify into, it's a large topic actually, so I will be confining to the acute stroke therapy because there are equally important views and learning points in acute stroke management, which are interval stroke management, stroke prevention, which is completely a separate topic, and stroke, of course, the rehabilitation. So the basis of acute stroke therapy is the recanalization, which is the most acceptable hypothesis, because this is the basis of having a stroke, is an occlusion of an artery, either through the native vessel being a disease because of the atherosclerotic plaque, or an embolus traveling from some source of the vascular circuit into the brain artery. So in the most simplistic way and in the most common sense way, the treatment of stroke would be just to open that artery. However, there are several biological factors weakens the relationship of recanalization and outcome in acute stroke patients. And one of the most common and challenging point was the tolerance of the ischemia by the end organ, which is brain, which is entirely different than many other organs in the body. Especially, we have seen that its success rate of in myocardial infarction, where the tolerance of the hypoxia by the myocardium is much different than the tolerance by the brain. So time plays an important and a crucial factor. Apart from that, there are many parameters like potential circulation, reperfusion is another very important parameter, which actually has to be considered, because if you recanalize a vessel beyond the repairable window period, you are doing a futile exercise of recanalization, because it leads to a reperfusion injury in the form of hemorrhage or red transformation of the infarct. So there is a very clear-cut correlation which has been observed in the last few decades, since the time we had IV thrombolysis established in 1990s. The revascularization of an artery has a direct correlation with a clinically good outcome. And there is a strong evidence in this regard, which has been studied in several reports. And it is not only that it has a very high, what we call clinically good outcome, with the recanalization, but it also reduces the mortality at 90 days significantly without significantly affecting the hemorrhagic transformation of these strokes. So in the past, in the recent past, in 90s, I would call it, that 90s was a time when the neurointervention was coming into the arena. And this primarily came for the purpose of hemorrhagic stroke, more popularly into the aneurysmal management of subarachnoid hemorrhage. Now, the popularity of endovascular approach and visualization or understanding of the microangio architecture by microangiography led a lot of interest into the interventional management of the stroke patients also, where IV thrombolysis probably would not be effective or beyond the window period. For example, from 90s till almost 2010 was a period there was a lot of experimental trials were conducted because there were still significant number of cases which were not in the ambit of IV thrombolysis. One of the commonest reasons was delayed reaching to the hospital or relative contraindication in those cases for use of IVTPA. So the question was that can we do recanalization without use of any chemical drug in these cases? So that's where the interest of the interventionists came in. However, there were several trials for conducted there until 2010. We did not see any significant beneficial, what you call, effect of the endovascular management of acute stroke patients. However, the interest did not die off. And what we had in 1914 was a Mr. Clean trial. The MR Clean, which was published from Netherlands, was an important trial because this was in many regards, which we had discussed in the previous article, that there were enormous heterogeneity in the trial design, which was not there in these group of patients. And the commonest thing was that they all used the stent retriever device in almost more than 80% of the cases. And this study has led to a very clear verdict that endovascular intervention in select group of patients would be a beneficial or safe, beneficial as well as safe proposition. And to support this, subsequently, many trials which were undergoing like ESCAPE, RIVA-CAS, SWIFT, PRIME, they were all interim aborted because of the positive result of the MR Clean. And the interim analysis showed that they were equally in the same line as the MR Clean data. So coming on to the point of stroke recanalization, which is the center of acute stroke treatment. How do we achieve it? We achieve it through IV thrombolysis, which has been doing it, quite effective, but does not apply to all stroke patients. And there comes the mechanical thrombectomy. We'll see what are those cases that we are. In spite of present, what you call standard operating practice of having intervention within the fold of acute stroke management. I'm talking about my experience with Zurich, which is an established center of stroke management. IV thrombolysis still remains the front line of the treatment. This is a very important point I want to highlight upon. So there is still, we are evolving into the knowledge base where certain group of patients can be and possibly taken directly into the thrombectomy without giving IV thrombolysis. So in the present situation in the world, all across the world, majority of the cases or large number of cases, standard operating practice, IV thrombolysis, if the patient has an indication for IV thrombolysis, must receive it, and then to be bridged for mechanical thrombectomy. Now, there are several factors which determines this whole paradigm of treatment, right from the age. So depending on age, I would not go into the more detailed aspect of it, but age, window period particularly, etiology, whether it is a embolic stroke or a primary atherosclerotic stroke, hemodynamic stroke, there are different mechanisms of the stroke. And from the etiopathological point of view, let's say the cardiac source of embolization, it has in a normal M1 artery, is a strong candidate for a mechanical thrombectomy. On the contrary, if you have an atherosclerotic disease in the M1 segment or the middle cerebral artery, the outcome would be entirely different than the previous example. So when you are undertaking these procedures, you have to have a very clear-cut goal of outcome and a very imbibing dialogue with the family in particular. Because end of the day, many strokes which are I would say morbid, but they are good stroke because they have a good collateral circulation, and many of those situations over a period of time, over a few weeks or a few months, there is a significant or sometimes complete recovery even without any recanalization of these vessels. So this balance has to be made, which is I personally feel is not addressed by the statistical analysis of the studies or randomized trial or meta-analysis. It is more of a personal experience that you develop based on those guidelines when you start practicing this subject. Similarly, the technique of mechanical thrombectomy in the past few years has significantly evolved because concurrent development of these devices with the advanced technology that is available today has made the procedure much more simpler or easier, I would say. Not simpler, but definitely safer and faster. So again, to choose a particular technique, one has to look at the etiology, nature of the clot. Clot burden is very important factor because it's a high volume of clot versus a tiny little clot of a 5 millimeter diameter length would be having a completely different implication in terms of technology, the technique that you imply. So in a small clot which is obstructing the M1 segment, probably a just single suction thrombectomy, which takes less than 15 minutes of the whole procedure, would be very effective as compared to a large burden of, let's say, 3 centimeter of the clot or 5 centimeter of the clot sitting into the internal carotid and across the M1 will have a completely different technical exercise, both in terms of complexity and duration of the procedure. So all those things has to be taken into consideration. And last but not least, in our environment, I would say that economics plays a very important role because unlike in the West, where there are standardized operating practice by the reimbursement by the insurance system, we do not have such a method actually, and we have to make a very clear dialogue with the family that how much cost will be implicated and how much chances of benefit are going to be in these cases. And I call it a dynamic decision making because decision has to be constantly changing actually, because at an X point of time, if you have decided for the procedure and you are going in a procedure after 2 hours or 1 hour later, it's a completely different scenario of the penumbra and the core in the stroke patient, because stroke is a dynamic disease. So decision also has to be very dynamic. From IV RTPA, we learned that time is brain, very important point of view. And that was the reason for the success of IV thrombolysis, which came through extreme awareness of the society and the physician and working out the whole system to reduce down the time from what you call onset to the needle time. And that we have learned that time period is a very crucial and important factor. And generally speaking, we consider 3 to 4 hours is a good window period for any stroke patient to be benefited in general. But there are exceptions. There are cases where patient comes within 30 minutes and IV thrombolysis, I would say, would be contraindicated rather, or we will not do it. I will show you based on our advanced or better understanding in terms of collateral circulation, which we reveal through the perfusion study, which are easily available to us. If you have a patient has a bad perfusion score, coming within the 30 minutes of IV, what we call window period of time, it will be a futile exercise to even give IV thrombolysis in that year. Forget about mechanical thrombectomy. So there are many exceptions to these cases. And that's why we also learned that there are possibilities you can benefit the stroke even 8 hours later. On the contrary. So there is a prolongation of the window period also possible, subject to the point that the patient has a very good collateral circulation. And usually these are the cases who have a low NIH score, but they are rapidly fluctuating with the fluctuation in the blood pressure sometimes. However, stroke outcome, as we learned, is a time dependent, and these are common statements that are used that we should rush because you lose almost 2 million neurons in a minute time that you delay. So these are only the, I think, hypothetical parameters that we have, but these are the objective or purpose is to be fast in a calculated way. 360 minutes is a usual cutoff point that we consider overall, and the best time that we consider is about 300 minutes from the onset. So the recanalization rate that we had in IV thrombolysis, we could achieve only up to 30% of the cases of the stroke. That means in 70% of the cases of stroke, we cannot offer benefit by IV thrombolysis. There could be several reasons. Let's say, for example, a patient with a lacunar stroke would not be benefited by IV thrombolysis. So I'm not talking about those group of patients. I'm talking about those group of patients who have a large vessel occlusion, but they are not responding to the IV thrombolysis. And if you apply carefully intra-arterial RTPA or urokinase, which I have a large experience, significant experience in almost 2 decades or more than 2 decades, you can transform these cases to a very good, effective recanalization. So I would like to emphasize this specific point here, because the whole world is moving in terms of use of a device, which is industry-driven also, because it's quite expensive proposition. But I would consider that RTPA, in my personal view, still holds its place, which is actually being aborted at the scientific evaluation, which I can talk about, which we have written down also in one of our articles, views and perspective. We can discuss this point at some other phase. Mechanical thrombectomy can achieve a recanalization as high as 80 to 90%. So that is what significantly we have achieved. And this is achieved at the cost of safety. It can be achieved in a safe way without giving a complication rate of the procedure. That is very important. So here comes the learning curve, and here comes the training programs, and here comes the dedicated manpower development, which we are focusing on. So time is brain was the slogan that we used to carry forward in 90s, which we have moved actually today. It's not the time which is brain actually. Time is the knowledge is the brain. So this is a more, I would say, thoughtful and scientific and artistic way to approach this strategy. And this is the device actually which turned around the whole game of stroke management, which is called stent retriever. This was, by the way, this was not a design created for purpose of doing, the thrombectomy. This was an accidental discovery because this was a stent which was created for the stent-assisted coiling, and it failed in that situation because it was a specific kind of a stent which was attached to the wire, and you can detach it by thrombolysis. So it has a lot of positive aspects. But because of the thrombolytic behavior, electrolytic behavior, it was more thrombogenic in those situations. So it went out of the popularity in stent-assisted coiling in aneurysm cases. So if you look at the revascularization, what we understand from today, away from the time window, that is the knowledge base, we have to understand the cerebral circulation, concept of penumbra, collateral circulation, and clot burden, which are some of the important, I would say, parameters which are to be looked at. We all know that brain is a very, very precious organ and very specific and unique organ in many, many ways. And that's why one of the important things is that it has just 2% of the human body mass, but it consumes about 2% of the cardiac output. It is a highly metabolic tissue in the body. So any organ which is highly metabolic is highly vulnerable also. And that's what it is. So whenever we have a normal circulation which is average from 50 to 55 milliliter per 100 gram of the brain per minute is the normal circulation. If it reduces to half, roughly around 30 milliliter, then there is a oligemia which sets in, and the patient starts becoming positive, hypoxic. But if it goes further down to the level of about 20 milliliter, then you start developing the penumbra region, which is actually the loss of electrical activity in the neuron happens, but it's still reversible if you can give in time the recirculation to this tissue. But if the blood flow goes below 10 milliliter per 100 gram, then there is a complete ischemia to the tissue. And whatever kind of recirculation that you perform in these cases, this tissue will not revive. That means it will not bring any recovery. So what brings the recovery when we do the intervention, either by recanalization by IV thrombolysis or by mechanical thrombectomy, is a oligemia and the penumbra region, which is suffering, which is still about to die. So if you do not intervene in time, then the cell death and infarction sets in, and we have a cascade of events which are happening at a molecular level, which essentially starts with the development of ischemia, decreased energy production, release of excitotoxic agents, activation of leukocyte, inflammatory process, cascadic phenomena, ultimately breaking down of the cell membrane and tissue loss. So what is this simplistic way? Let us look at this cartoon in the penumbra concept. So when there is an oligemia which is less than 35 milliliter per 100 gram, you see this orange zone. And the penumbra tissue, which is the red zone, is at a 20 milliliter. But it is highly vulnerable and dynamic in terms of merging towards the center core, which is black. So this is whenever we do the perfusion study, is a static test. It's not a dynamic test. So if there is a delay in assessment of that CT and perfusion study by 1 hour, the whole penumbra has completely changed by that time. That you must have to take into account as a correction in your decision making also, because you can't repeat every 1 hour the perfusion study. But if at 6 hours, this is what the situation happens, that the core, which is the penumbra, does not receive the revascularization, and it succumbs to the infarction, and it becomes not salvageable. So in undertaking, especially when you are undertaking this whole gamut in an interventional way, because interventional way, when you are taking it, you are navigating into the intracranial vessels, which are very, very sophisticated. They are very, very, I would say, sensitive and highly vulnerable for any kind of trauma that are possible and may eventually lead to some kind of a intracranial hemorrhage immediately or subarachnoid hemorrhage immediately. So as an operator, unlike the pharmacological drug, which is RTPA, would give you something like a risk of about 1 or 2% of hemorrhage. Here you might have a higher rate depending on the operator who is performing these procedures. So the whole understanding of the vasculature should be understood not from the morphological point of view, but at a micro circulation point of view, as well as from the collateral circulation point of view, which is of different types, extracranial arterial circulation or the intracranial collateral circulation. And we have understood from our IV thrombolysis, again, studies from the IV thrombolysis protocol, that you can define on the source image of the CT angiogram, what we call the score of the collateral circulation. If there is no vessels in this area, this is score 0. This patient is not going to tolerate the ischemia for longer period of time. So these are not the ideal cases also for IV thrombolysis as well as for the recanalization strategy. But the moment you have a score of the 3, you have a very high probability of recanalization, even if it is delayed. For example, at 6 hours or 8 hours, these are the patients that tolerate the penumbra and the oligemia for much longer period of time because of good collateral circulation. I will not go into this detail of the collateral circulation, but these are the pathways that we have been following for a long time, but it continues to be the same even today. So there are subsets of the patients which are coming to our emergency which do not qualify for IV thrombolysis, which do not qualify for mechanical thrombectomy, but they qualify for the stroke care management in a specific way, which is not going to be my topic of today. IVTPA is the first line, as I already said. We bridge them to the endovascular therapy, but there are certain group of patients, especially in my personal practice, we have defined, and again, it's beyond the scope at this lecture, where we are actually bypassing the IV thrombolysis and they make a strong rationale without, in my personal view, without undertaking them into any randomized trial for that matter. Now, I want to show you that this is the pathway that we followed in Zurich, and I just want to give you a view onto it, that how simplistically we can organize, because it's organization of the stroke program which is more important than actually delivery of care to an individual patient, for example. It has to be repeatedly provided to all patients which are coming to you 24/7. Majority of the stroke comes in the night, in the odd hours of the day. And anybody who is involved in either IV lysis program or mechanical thrombectomy has to be available at every odd hours of the night, rather, maybe not in the day, because they call you in the night or early morning, 3 o'clock, 1 o'clock. You're going home, you reached home at 9 o'clock and you get a call that there is a stroke. You have to turn back immediately. So how we organize, because it's not possible by one person to do it. You require a teamwork. And how we create the team. This is how the patient comes to the Notfall is an emergency area. So the patient comes to the emergency and a neurological examination done by the history neurological examination, primary investigation, done by the frontline stroke team. And they will take the patient to the CT scan room, and the moment they find that there is a large vessel occlusion, they will start IV thrombolysis also. Once they rule out that there is no hemorrhage, IV thrombolysis would be given here. Was it not 45 minutes? 30 minutes. Okay, all right. Thank you. So just let me know when to stop. So once you see that there is a large vessel occlusion, a neurointervention team would be called upon who are at rest at home, for example, in the night. So they are not on the front line actually immediately. The front line is a stroke team, so that the moment you find that there is a large vessel occlusion, you make a decision based on the perfusion study and the level of occlusion. Are you going for the procedure in this particular case? If you're going for the procedure for the case, you alarm that we take this patient, so our anesthesia team immediately comes in the anesthesia in the CT room itself. And we take this patient. If it is not for the intervention, the stroke team will take the patient to the stroke unit. Otherwise, the anesthesia team will take to the interventional suite, where we will have at least something like 20 minutes time to reach to this place, and you start the procedure. So there are two kind of imaging methods which are used today for the acute stroke management. One is a CT-based protocol, and second is MR-based protocol. In the Western world, both protocols are available, but largely easier and the faster is the CT-based protocol. And for the Indian environment, my strong recommendation is that we should stay only on the CT protocol. There are exceptional cases, which I will talk about, some of them, where the MR is supplementary, what you call investigation as a protocol, a stroke protocol. Otherwise, in all stroke patients, we do plain CT scan to rule out any hemorrhage or consider the aspect score, and we do the perfusion study to determine whether there is an indication for revascularization in that case. It doesn't matter whether you are doing with the IV thrombolysis or by means of mechanical thrombectomy. It doesn't matter. Perfusion is a very important selection criteria for IV thrombolysis also, because if you have a large perfusion deficit, then it makes sense. But you have a large core and a small perfusion area, then you do IV lysis, you recanalize artery, and you get a massive reperfusion hemorrhage. So those are not a good what you call management plan, because then the surgeon has to come in, and the decompression and the whole cascade of the secondary effects which are there are again very, very non-rewarding. And third most important thing in the protocol is that we do CT angiogram altogether. So the whole protocol takes about less than 8 minutes time to perform, and it takes another, let's say, 5 to 7 minutes to study the perfusion, to recreate the perfusion, the post-processing, and make your decision on these things. Second is an MR-based protocol, and MR-based protocol, again, we follow in the same way. That I'll show you what are the sequences that we perform. So here is an example of a 60-year-old gentleman with aphasia, right side paresis. you see there is the aspect is practically 10. So there is no gray-white. And on perfusion also, you see there is only a small area which shows a volume restriction. Otherwise, there is a large penumbra. So what is the interpretation of this case? Just based on CT and CT perfusion, that either it is a large vessel occlusion with a good collateral circulation, which actually I mean by the internal carotid artery. It could be in the cavernous sinus region, or Peters region, or is commonly in the bifurcation region, or a distal embolism with a restrictive lesion. So we look at now the CT angiogram. What you see here is the M1 is preserved. Now what you see here is that there is extremely severe stenosis over here, and a severe. So it is possibility that this is an unstable plaque or a ruptured plaque which caused a small emboli into the peripheral cortical branch, and the large area that we see is all due to the hypoperfusion because of the stenosis, and this is completely modifiable. So that is what I think the important thing is, and that is where we decide that not only what would be here it will not be the thrombectomy. Here straight we will go and do just the carotid stenting in this particular acute stroke patient. So this is not an acute mechanical thrombectomy, but the earliest prevention, a secondary prevention of a stroke by means of urgent what you call carotid stenting. On the other side, MR-based protocol that we perform are, you have to just choose selective sequences because you don't have to do the full MR. It's time consuming. If you just perform diffusion, flare, or T2 star and SWI, sufficient. It takes 5 to 7 minutes to perform, less than 10 minutes. So in 10 minutes, you have a complete, situation with you for your decision making. For example, on acute stroke, you will see on a diffusion weighted image. But if the flare is not showing any impairment, then this is the ideal case for revascularization. Even though your perfusion study is pending, actually, which relatively takes longer time in MR perfusion study. But we also do MR-based CT angiography. So protocol remains same, the parenchyma, perfusion, and the vessels, either of the modalities that we perform. So which are the situations where we are primarily going for MR-based protocol? First, when you are suspecting or clinical strong suspicion is of a vertebrobasilar stroke. So in vertebrobasilar stroke, the CT will not reveal anything to you. So in these cases, what you do is an MR shows you very clarity that there is a basilar stroke. Look at this patient, 78, wake-up stroke. This is another example where the time of onset is unknown to us, and we are not able to decide whether the recanalization is within the window period or not. So here, time is not the deciding factor. The collateral circulation or the parenchymal viability in terms of oligemia is a decisive factor. So how do we determine? We do see here on the diffusion image that yes, there is a acute ischemia in the basal ganglia region and corona radiata, but there is a large perfusion deficit here. And on MR angiogram, you see the complete cutoff in the M1 segment. So this is an ideal case for IV thrombolysis, and you give a 20-minute patient at a complete recovery. So you don't take the mechanical thrombectomy in this case. So then what you do? You do an MR again, and you see this MR shows that complete resolution of this ischemia with the patency of the M1 segment over here. Thrombectomy options, I will quickly pass on to these 3 or 4 examples, and I will rest my talk after that. 69-year-old gentleman, right hemiparesis, aphasia, NIHSS 10. Window period 4 hours, aspect score 10. Very good case. So what you do in this case with a minimal deficit? What you find over here is that there is a restrictive lesion in the M1 segment over here, a very short segment. Patient received IV thrombolysis, immediately taken to the cath lab. What you find here is a partially flow limiting thrombus in the middle of the middle cerebral artery over here, short segment. Straightforward case. You take your, this is the suction catheter, this is your retriever device, and you do suction thrombectomy, you completely revive this artery. It takes 15 minutes, less than 15 minutes actually, this procedure. Lateral view, always we see it because the cutoff in the vessels or the what we call the secondary stroke is another important thing. So it's not the just the recanalization of the segment. Sometimes you recanalize the M1, but you dislodge another clot in the peripheral artery, let's say Rolandic here. It's worse stroke than what it was before. So this is another challenge that you have to have, and any learning curve or any, the quality standards that you have to create has to be created on the right perspective of analysis of a post-procedure angiographic and MR evaluation of all these cases. Another example on the contrary, 53-year-old gentleman, AF pacemaker on dabigatran. This was many years ago, almost 9 years ago. This case was a midnight stroke. Patient was living very close to my hospital in Delhi and reached to the hospital in 30 minutes. Hemiplegia, worsening sensorium. My cardiologist colleague called me, Shakir, this is the patient, we can't do live lysis. So on angiogram, on CT scan, you can see a large, dense MCS sign. Already, the large clot burden, maybe more than 2 centimeters. So when you already know that this is a high clot burden, even if it is without dabigatran, is not a candidate for IV thrombolysis. What you see on angiogram, complete occlusion of the ICA. Study the collateral circulation, go into the ICA, perform the pass. First pass, you capture some of the clots, but second pass that you perform again into the proper placement of the retriever device, and you pull out this 3 centimeter long clot. Once you remove it off, you have a complete normalization of the circulation. Essentially, as I keep saying that, see on the lateral view, there is no distal cutoff in any of the cortical vessels. And you have a complete recovery in this particular patient in a fastest possible way next morning, actually. You do a CT at the time of the, on the machine itself, most of the new machines have this flat panel CT. We do right away over there, no, what you call middle cerebral artery hyperdense sign. So important thing that what we have learned in last about almost a decade now, where that we are doing quite a bit of mechanical thrombectomy now. And for last 5 years, knowledge is quite strong, because last 5 years has been, 5 to 7 years has been a time of a high development of high expertise in terms of performing the procedure all over the world. So the results before 5 years were different, and last 5 years are quite different actually. So what we know is that first pass effect, we call it. You can recanalize this artery, let's say taking time of 2 hours or 3 hours, making 7 passes, 10 passes, 9 passes, whatever number of passes. It doesn't make sense. And we learned from it, from the study analysis, that the best clinical parameter recovery comes in the first pass effect. If you can open the artery in the first pass itself to the level of TK3 or TK2C, which are effective recanalization, then you have a corresponding high probability, almost to the tune of 90%, that you can guarantee that there is going to be a clinical recovery. So that is a level of knowledge that we have now understood, and we are very confident, dogmatic about this knowledge base. Another case example, 60-year-old gentleman, prolonged right sensory hemiparesis, NIH, very little, 7, thrombolysis given, and this was the study. This is the plane scan. This is the CT angiogram that's showing that there is some degree of stenosis here in the M1 segment, and this is the corresponding perfusion study, small core, large territory of perfusion deficit. So in this particular case, when we took the patient for what we call recanalization, we found that there was a complete occlusion of the M1 segment. It was progressive disease, and we did the first pass, and after the first pass, we recanalized this artery. And this was the re-occlusion of the artery. This is the second pass going on. And after the second pass, again, there is an opening of the artery, but again and again, this is getting re-occluded over here. Now, in this particular case, question was until what point of time you will continue to reopen this re-occluding artery. This artery gets occluded again and again after 1 minute or 2 minutes of recanalization. So this is a very important thing that one must have to keep a thought in the mind, that I particularly consider 3 passes as my limit. That until 3 passes, if I'm not able to recanalize the artery to an effective recanalization, I abort the procedure, because that otherwise also consumes a lot of time. And these are mechanical things. So you are working on a shadow of the contrast on the machine. But on the other side, you are traumatizing the artery. So sometimes you cause more harm than the benefit. So we essentially say that the primum non nocere should prevail all the time in your mind, even when you are in procedure, so that you can abort the procedure in time without harming the patient. So we stopped the procedure. This was essentially the outcome of this patient. The next day, he had a large infarct. Had we continued to do more, actually, probably we could have transformed this all into a hemorrhagic transformation. So this is very important, that when to stop and what are the reasons of failure of the recanalization. This is another topic which we have to constantly discuss and talk about it. So I'll go quickly onto this. I'll not discuss what are those parameters and what are those points. I think it will become too long. Just last maybe example, that another case of right hemiparesis, aphasia, NIH of 18, window period 4 hours, IV lysis given, aspect score 9. So at this point of time, what you do is that this is a plain CT scan, very good aspect score, only just a small area of hypodensity here, and a good perfusion study for intervention. So in this particular case, we went ahead, but what we found that there was not an M1 occlusion. There was a left common carotid artery shows there is no internal carotid artery over here. And all collaterals are coming from the right internal carotid artery to the anticommunicating artery and the leptomeningeal collaterals. So what do we do in this case? First, we have to open the internal carotid artery here. So we opened up the artery here, which is reasonably completely occluded over here, and dilatation, and not to stent this artery. Straightway go to the middle cerebral artery first, because you have to revive the tissue first. So you go up, do the thrombectomy, open the MCA, while coming back, deploy the stent and repair this artery. So this is a combined procedure that you have to perform. So it's not just a mechanical thrombectomy, it's a etiology based or the nature of the stroke based intervention. This is also a long topic. So if you want, I can stop here. Is that fine? So I think, thank you very much for your attention, but I'll conclude with the last slides. That what is important is, on one side in stroke management, we have a revascularization strategy by IV thrombolysis or mechanical thrombectomy. We have to weigh the pros and cons. So when we are weighing pros and cons of mechanical thrombectomy, the person who is performing the mechanical aspect of intervention, he has to evaluate his own risk, because IV thrombolysis risk is ubiquitously known. But in a particular environment, my risk would be different, and in another environment also might be different, or my risk would be different than higher than the other person's risk, for example. That has to be understood, and the type of occlusion and collateral circulation to be studied to make a decision. And on the other side, one has to analyze what are the possibilities of recanalization. What are the technical challenges that are there that make your procedure easier or complex in terms of number of passes and duration of procedure that you consider. So this balance has to be weighed upon and I would say decided upon. I will pass on these slides again and come to my last slide. So time is brain. We used to talk about it in the past, but we talk today, a brain is time actually, because we have to apply our brain to save that brain. And that is very fundamentally important strategy, because time is a very important dimension. It's still most important dimension, but there are many other dimensions of knowledge base which we have to understand, especially as I mentioned, collateral circulation, penumbra, and etiology, clot burden, things like that. Acute stroke is a diverse disease in terms of etiopathogenesis. So even if from the mechanical recanalization, it has to be answered in the same way, in a diverse way. It cannot be just mechanical thrombectomy. Understanding the etiology and mechanism of stroke is important to make revascularization a successful strategy immediately and also for the secondary stroke prevention. So I thank you for your kind attention, and if there are any questions and there is a time, I would be happy to answer you. Thank you.
Thank you, Dr. Shakir Hussain sir, for extensively covering the stroke system of care and telling us that it all depends on various factors what will be the outcome. Thanks a lot.
Thank you, sir. I would request Dr. Trilochan sir and Dr. Vikram Bora sir to present an award to Dr. Shakir.
Thank you. Very nice. Very nice. Thank you.
Thank you, sir.
Thank you.
Now,